Yes, I can see it very well. Okay, thank you very much indeed for giving me this opportunity. I will be just covering the how we diagnose PE just very quickly, and then I will touch on the PE in COVID-19 at the end of the lecture. So if we start with, can we go to the next slide, please? Yes, on this slide, you can see the pathway of diagnosis PE, and I think this pathway properly in every hospital. Normally, we divide people according to the clinical probability to high clinical probability or low and intermediate clinical probability. One of the new changes in the pathway is what they did, they simplified the pathway by combining the low and intermediate clinical probability in one group. And we can call it PE unlikely or pulmonary embolism unlikely. On the other hand, we have the high clinical probability where we call it pulmonary embolism likely. In that arms, what we do, we go straight away to CT pulmonary angiogram. We don't need to do any blood test. And if it is positive, we treat. If it is negative, we don't treat, or some people say that you might need to pursue the investigation further or think of alternative diagnosis. On the other hand, if it is PE, pulmonary embolism unlikely, or PE unlikely, then we do D-dimer. And the reason we do D-dimer because we thought by doing D-dimer, we are going to reduce the number of imaging. I'm really sorry about the telephone. To reduce the amount of imaging, the number of imaging. And so if it is D-dimer positive, we'll go and do CT pulmonary angiogram. If it is D-dimer negative, we don't do any imaging and we exclude pulmonary embolism. So if we discuss the clinical probability, now we have simplified this into two levels, either pulmonary embolism unlikely, and here the Wells score, what you call a modified Wells score, will be equal or less than 4. And if it is pulmonary embolism likely, then the Wells score will be greater than 4. And they found that when it is pulmonary embolism likely, then the chance of having pulmonary embolism could be up to 50% of the patient could end having PE. When it is pulmonary embolism unlikely, then only 12% likely to have pulmonary embolism. We did mention about D-dimer. We mentioned that D-dimer, when it came, it would be very promising, and it thought that this test will reduce the number of patients going for further imaging. Unfortunately, actually, D-dimer brought more imaging. And I'm just going to mention a small study which was done I think in North America. And in that study, what they did, they had 2 wards. One ward allowed them to use D-dimer freely. The other ward is not to use D-dimer at all. And at the end of the study, they found that the number of pulmonary embolism detected in both wards more or less the same. Mortality is more or less the same. Missing pulmonary embolism more or less the same. The only difference is the ward which allowed to use D-dimer, they use more imaging, they use more CT scan. And therefore, people thought this is actually D-dimer is a problem rather than a solution. And we should think of changing our policy. So they thought either we reduce the number of patients going to have D-dimer, or we increase the normal level of D-dimer safely. So this is the thought how to reduce further imaging. Either you reduce the number of patients which is going to have D-dimer, or you increase the normal level of D-dimer. And whether we can achieve that or not, we'll see. There is something called pulmonary embolism rule out criteria. We call it PERT. And this PERC actually designed by somebody called Klein, and he had like 8 criteria, including the age, the pulse, the saturation, the swelling of the leg, whether there is hemoptysis or not, and no trauma, and no past history of DVT, and no hormone use. And to rule out PE on the basis of PERC, you have to achieve all 8 criteria. So your age should be less than 50, your pulse should be less than 100, saturation greater than 94, you don't have a swelling of the leg, you don't have hemoptysis, you don't have trauma or surgery, you don't have past history of PE or DVT, and you don't use hormones. So if you look at these criteria, you find them, they are very robust criteria. And usually we use it with low clinical probability. So now only low clinical probability. And this is a meta-analysis done by Sin et al. And what he did, he collected about 12 studies and pulled the data together. And they found that using these criteria, you can exclude PE in 97%.
Sorry, Dr. Muntasir, sorry to interrupt you. Which slide?
Yeah, you just go to the next slide. Sorry.
This one?
Yes. Sorry, I'm really sorry. Okay. I should say okay. Next slide. So what they did, they found that the sensitivity of this criteria in excluding PE is 97%, and you miss PE in 0.3%. Only 44 patients out of more than 13,000, they miss PE. Can we have the next slide? So, PERC criteria can be very useful in avoiding imaging, and if used in conjunction with low clinical probability. No, not this slide. Not this slide. No.
Sorry, yes, I'm starting from the beginning. So the first slide.
Yes, this one. Yes, stay. So PERC criteria can be used to avoid imaging and to avoid doing D-dimer. However, you have to understand the limitation of PERC. One of the limitations of PERC that they are not very good in evaluating people with pruritic chest pain. Actually, pruritic chest pain was not included in the criteria, and it neither included, not this one, the next one. No, before that. Yeah, stay in this one. PERC criteria has got some limitation. One of the limitations that pruritic chest pain is not included in the criteria, and they found actually people with pruritic chest pain, when you use PERC criteria, the chance of missing PE is higher than normal, and therefore this is one of the limitations of PERC. Also, if the patient is pregnant or recently delivered a baby, then PERC criteria might not be good. And if the patient on beta blocker, because these people actually were excluded from the studies, because one of the criteria in PERC is the heart rate. And if you are taking beta blocker, then your heart rate will be modified by the beta blocker. And finally, people with thrombophilia screen and family history of VT, you should not use PERC criteria. Can we have the next slide? Next slide. Yes. Now, so we've seen how we can reduce the number of patients which can have D-dimer by using what you call pulmonary rule out criteria or PERC. Now, the question is, can we also increase the normal level of D-dimer we use? It has been noted that D-dimer is very high in elderly people compared to young people. And this could be attributed to many factors. For example, one of them is they have got higher fibrinogen concentration. Their kidney function is not as good as in young people. They might have occult malignancy or some chronic inflammatory process or inflammatory disease. And that's why you'll have D-dimer abnormal above 500 in elderly, more likely than in young people. And if you look at this curve, you can, if you look at the black line, you can notice, you can see that D-dimer, can you go to the next slide? If you look at this curve, you can look at the, the black line where D-dimer is, the level of D-dimer increasing with age. At the same time, the specificity of D-dimer is less as people get older. And therefore, you'll have, in old age, you'll have more D-dimer, which is unlike and less likely to be very sensitive test in old age. Can we go to the next slide, please? In this study, you can see that if we use the dimer, you can find that in the old age, in the patient with 80 years old, the gray part of the bar is actually the number of D-dimer, but no PE. And the green part is the number of patients with positive D-dimer and positive PE. And you can see, although there is a big number of patients have had positive D-dimer, but only a small percentage had pulmonary embolism. So the specificity of D-dimer is less with old age. If you look at the other one, with the patient with age 40, you find that the number, the green part is slightly bigger, and the number of PE found with positive D-dimer is more. And therefore, D-dimer might be good in excluding PE in young age, and is not very good in elderly age. Can we go to the next slide? Yes. So there is, so what, no, next slide, yeah. So this slide, yeah, stay in this one. So in this slide, you can see there is somebody called Dorma, and he did a very big retrospective study, and he used what we call age-adjusted D-dimer. If your age is above 50, you multiply your age by 10, and that should be your normal D-dimer. So if you are 65, your normal D-dimer should be 650 rather than 500. If you are 80, your normal D-dimer should be 800. And what he did, he used this age-adjusted D-dimer in a retrospective analysis of data, and we found that he can increase the number of negative D-dimer from 9% to 20% without having false negative. Now, can we go to the next slide, please? Now, this age-adjusted D-dimer has been evaluated by multi-center prospective study in 19 centers in Belgium, France, Netherlands, and Switzerland. And they included more than 3,000 patients. And they use either Geneva score or Wells score to evaluate the clinical probability. And the endpoint was to see how many pulmonary embolism missed if you use age-adjusted D-dimer. Next slide, please. And they found if people above age of 675, they found there is 673 patients. And those who have got no high clinical probability, that means they are pulmonary embolism unlikely. They found that they excluded pulmonary embolism in 200 rather than 46 using age-adjusted D-dimer. So they increased the exclusion of PE by 5-fold. And they noticed that they are not missing PE in a lot of patients. They miss PE, pulmonary embolism, in 0.3% if you use age-adjusted D-dimer, which if you compare it, if you use a normal conventional D-dimer, they are missing PE by 0.1%. So you can say from this study, from this trial, that age-adjusted D-dimer can safely be used to exclude pulmonary embolism and without missing significant numbers of pulmonary embolism. And age-adjusted D-dimer now included in the guideline of American College of Physicians, also included in the European Society of Cardiology, which is endorsed by the ERS, which is the European Respiratory Society. It has not been included in the American Thoracic Society because they felt that in the different centers use different way of assays, and also has not been included in NICE guideline. Having said that, I suspect they will be included, and in actual fact, we are using it in UK. We are using it in our hospital. And I think it is very helpful in reducing a lot of imaging, especially in elderly people. You don't want to subject this to CT pulmonary angiogram unnecessarily, especially the renal function test might not be as good as in young people. The next slide. The next slide also. Sorry, I discussed that one. Now, we're coming to CT pulmonary angiogram. Is it doing the job? People thinking whether do we need another test with CT pulmonary angiogram, or can we just rely on it alone in excluding pulmonary embolism? Can I go to the next slide, please? What we use now is multi-detector CT pulmonary angiogram, and these are very good in even detecting sometimes segmental and subsegmental pulmonary emboli. And in the BioBet2 trial, they found that the sensitivity of the CTPA is 83% and the specificity is 96%. Can I go to the next slide, please? However, they noted also the sensitivity or the negative predictive value of CTPA in PE depend on the clinical probability. If you have low clinical probability, then the negative predictive value is 96%. On the other hand, if you have high clinical probability, the negative predictive value of CTPA is 60%. And based on that, they felt that probably CTPA we cannot rely on it alone in excluding pulmonary embolism in patients with a very high clinical probability. And it's recommended that we can, if the patient have a high clinical probability and at the same time have a negative CTPA, we should do a VQ scan or ultrasound of the leg before excluding pulmonary embolism. Having said that, we don't do that in practice. Actually, in our practice now, if the CTPA is negative, then pulmonary embolism is excluded. So are we doing the right things? Let us see more study. Can we go to the next slide, please? Now, in these are 4 studies. The first 2 are prospective studies, but the second 2 are trials. And in the first one, you can see that they used pulmonary CTPA plus ultrasound of the leg. And they found that the ultrasound of the leg just detected DVT or in only 0.9% in patients with negative CTPA. So the number of PE missed with negative CTPA is not too big. The same thing, the other study, which is number 2, we found that people with negative CTPA were followed for 3 months. And within these 3 months, they found that pulmonary embolism was missed in 1.1%, which is still not a big number. And then we have a Canadian trial where they compare VQ scan plus CTPA. And in this trial, actually, they found that with negative CTPA, pulmonary embolism was missed in 1.5%. And also there's another European trial, which is the last one in the slide. And you can see that after 3 months, they found that they missed PE in only 0.3% in the people who had only CT scan. They compare people with CT scan against people with CT scan plus ultrasound. So if you take all these studies together, you can say that it is safe to exclude PE on the basis of a negative CTPA. And probably whether we need further testing in a patient with high clinical probability remain controversial, and each individual should be dealt with on individual cases. So you use your own discretion whether you need further tests or not. Can I have the next slide? In actual fact, people think that CTPA is not missing PE. CTPA is overdiagnosed pulmonary embolism. And this is a very interesting study. It is a retrospective study in a tertiary center. What they did, they collected all the people who had a CTPA, and there was 937 cases have CTPA. And initially, pulmonary embolism was diagnosed in 174 patients. Then they got 3 radiologists, 3 experienced radiologists, and asked them to re-evaluate all these CTPAs again and to see whether the diagnosis was right or wrong. And the result was actually very interesting, because after they evaluate all these CTPA again, they found that in 45 patients, which is about 26%, 1/3, there was no PE. Originally was diagnosed to be PE, but they found that there is no PE. They believe that there was not, the pulmonary embolism was not there in these 45 patients. Can you have the next slide, please? So it felt that probably CTPA overdiagnosed PE, and especially this happened if you have got a solitary, very small PE, peripheral PE, diagnosing the CTPA, or if it is segmental or subsegmental PE. So this is very interesting study, and we have to take into consideration sometime are we overdiagnosing pulmonary embolism or not. Now we come to, can we have the next slide? Yes, we mentioned a few words about VQ scan. VQ scan used to be the screening test for pulmonary embolism until CTPA came along. And people believe that VQ scan probably is obsolete now. Having said that, it has its role. And especially it has its role if the patient has got a low clinical probability with a normal chest X-ray, if the patient is young, and is particularly in females, because people worried about the radiation to the breast with CTPA. In pregnancy, also, if you have got contrast allergy, if you have got severe renal failure, then we cannot use contrast. And whether to use it after negative CTPA with a high clinical probability, as we said before, it is controversial. The problem with VQ scan, if it is normal, then you can confident. Can we have the next slide? The problem with VQ scan is if it is normal, then we can confidently say that there is no PE. And if it is high VQ scan probability, then we can confidently say that you've got PE. The problem is when we have non-diagnostic tests, when we have low or intermediate VQ scan probability. In these cases, most of the time the VQ scan is not diagnostic, and we need further tests such as CTPA. And these actually 70% of the cases. So it is diagnostic only in 30% of the cases. And that's why VQ scan also has got its limitation. And that's why we tend to use CTPA more than VQ scan. Plus also CTPA is easier and to diagnose PE rather compared to VQ scan. Can I have the next slide, please? Now we're going to talk about COVID-19 and VTE with pulmonary embolism. From our limited experience with COVID-19, there is no doubt that there is increased prevalence of pulmonary embolism in patients with COVID-19. And COVID-19 is associated with abnormality in coagulation, such as prothrombin time, such as APTT or D-dimer. And actually, when we have abnormality in coagulation with COVID-19, then the prognosis is very poor. And they believe that there is many predisposing factors why we have PE in people with COVID-19. Could be the degree of inflammation, the DIC, disseminated intravascular coagulopathy, the hypoxemia, the immobility. And also, interestingly, people died with COVID-19, they did post-mortem and they found they have got microemboli, which you don't detect them with CTPA, and hemorrhage there. So still we need to learn a lot about COVID-19 and to understand COVID-19 more. Now, can I have the next slide, please? So when do you suspect COVID-19? It is, you should have a very low threshold in suspecting pulmonary embolism in COVID-19, very low threshold. And especially if you notice there is sudden deterioration in hypoxemia with unexplained decrease in blood pressure and tachycardia. And especially if the inflammatory markers are coming back to normal. And also if the ratio between neutrophil and lymphocyte also coming back to normal. In this patient, then if you notice that there is deterioration in their hypoxemia and also the blood pressure and there's having tachycardia, you suspect PE. And you have a very, very, very low threshold in suspecting PE in people in intensive care. About 1/3 of these patients develop PE. And you have to remember, even if the patient had been on prophylactic low molecular weight heparin, it still can develop pulmonary embolism. So it is a very risk factor, it's a very high risk factor for pulmonary embolism having COVID-19. Can I have the next slide, please? Now, the problem with diagnosis of PE in COVID-19 is doing the test itself. Because if you want to have the patient have a CTPA, precaution has to be taken to avoid infection of the staff, to transfer the patient to the radiology department is a hell of a job. Sometimes the patient might be in intensive care unit and attached to a ventilator, and it's very difficult to move him to CT scan. He might be very unwell, hemodynamically unstable, very difficult to move him to CT scan. And therefore, sometimes you have to treat the patient empirically. And therefore, they recommended to do some sort of risk stratification to decide whether this patient is likely to have a PE or not. And the risk stratification depends on 3 factors. First of all, location of the patient, whether it is in critical care or in the ward, high dependency ward. because people in critical care are likely to have pulmonary embolism. Also, disease severity, and also D-dimer threshold. I will discuss each of these three factors separately: the location, the severity of the disease, and the D-dimer. If we take the location, people with intensive care are likely to have PE, about 1/3 of them. And this is a study from the Netherlands. And 184 patients all have a standard VT prophylaxis. All of them had prophylaxis. And then they confirmed PE with CTPA and ultrasound in 27% of the patient, almost 1/3. And the end of the study, they recommended that there is high incidence or prevalence of PE among people with COVID-19, and they recommended actually higher prophylactic dose. Normally we use enoxaparin 40 milligram once daily, or dalteparin 500 milligram once daily. You use it twice daily in people with COVID-19. This is their recommendation. Can we have the next slide, please? Now, next slide, please. Can I have that? Yes. Now, severity of the disease, how we stratify people according to severity of the disease. If the patient at home, then it's less likely to have a pulmonary embolism. If the patient is admitted and in the general ward, probably less likely. However, if the patient is severely ill in a high dependency unit on CPAP with oxygen, then it's likely to have pulmonary embolism. And also one of the things we use is sepsis-induced coagulopathy score. And these depend on the prothrombin level, platelet count, and something called SOFA. SOFA is what you call a sequential organ failure assessment score. This is used in intensive care to evaluate the status of the organ and whether the organ is going to fail or not. It is a scoring system. You can Google it, and it is in the internet. But the Google here, or the sepsis-induced score coagulopathy, I gave it to you here, but it is, you can Google it very easily. And if your sepsis induced coagulopathy score is more than 4, equals to 4, then you are likely to have severe disease, and you are likely to have pulmonary embolism. Can we have the next slide, please? Now, D-dimer. The traditional teaching of D-dimer is, when it is negative, it is useful. When it is positive, it is useless, because we use D-dimer to exclude PE. So we want the normal D-dimer. If the D-dimer is high, we ignore it. However, or depending on the clinical probability, probably we do a CTPA, but generally we don't believe it is diagnostic for PE. In COVID-19, D-dimer should be used differently, because it has been thought that it has been felt, and it has been found that a high D-dimer is associated with, first of all, poor prognosis and likelihood of developing ARDS. And in a study in China published in The Lancet, and they found that if the D-dimer is 1500, then the chance of having DVT is less. But if it is 3000, then the chance of having DVT and PE is high. And they recommended, they felt that probably we could use D-dimer to see what treatment we should give. If the D-dimer is less than 1000, then PE and DVT are unlikely, and probably this is due to inflammation, and you can settle for using standard anticoagulant prophylaxis, like 1 dose of enoxaparin or dalteparin. However, if D-dimer is between 1000 to 3000, then you can use intermediate dose prophylaxis, where you use double dose, enoxaparin twice daily or dalteparin twice daily. And if it is more than 3000, then you should suspect pulmonary embolism. You should try to do a CTPA. And if you don't have a CTPA, you might want it to start treatment dose of CTPA. Having said that, this recommendation is not proven, but for the time being, while we're trying to understand more about COVID-19, it might be a plausible way, a plausible approach. Can I have the next slide, please? So according to what we said, we can divide the patient into standard risk patient, high risk patient, and likely P or proven or suspected PE. The standard risk patient you'll find usually in a general ward or at home. We're talking about the hospital. In general ward, he's not having CPAP, and his sepsis-induced coagulopathy score is less than 4, and D-dimer less than 1,000. And these people probably we just give them conventional prophylaxis. Then the high-risk patient, I put here the ward, but usually in HDU, in high dependency unit. Usually having CPAP, the sepsis-induced coagulopathy scores is more than 4, and D-dimer between 1,000 and 3,000. And finally, the very high one, which is likely to have a PE, and you might want to treat him empirically for PE, is a patient who's in intensive care, ventilated, sepsis-induced coagulopathy scores more than 4, and D-dimer is more than 3,000. Therefore, this is the PTS guidelines. Actually, it is a possible approach. It's still non-proven here, but it is a plausible approach suggested by the British Thoracic Society. So the standard risk patient, which we found them, which we usually in the ward. Can we go to the next slide, please? This is the British Thoracic Society approach, which is not 100% proven, but it is something, it is plausible and something which can be acceptable to you during these times till we understand more about this disease. So the people with standard risk patient, the patient who we said that he's in the general ward, his sepsis-induced score, coagulopathy score is less than 4, he's not in CPAP, and D-dimer is less than 1,000. We can just give him standard prophylaxis, which is enoxaparin 40 milligram once daily, or dalteparin 5,000 units once daily. Now, if you come to the high-risk patient, this patient, which we said that could be in high dependency unit, having CPAP and oxygen, and sepsis-induced coagulopathy score is more than 4, and dalteparin between 1,000 to 3,000, these people, you should give them a higher dose of prophylaxis, double dose of prophylaxis. So enoxaparin twice daily, or dalteparin 500 twice daily. And finally, the very, very high risk one, which is suspected to have PE, likely to have PE, with those who are in intensive care, those who are in intensive care has got sepsis-induced coagulopathy score more than 4, and on a ventilator, of course, and D-dimer more than 3,000. These people, you try to get the diagnosis of PE, and if you cannot get the diagnosis of PE, it might be justifiable to start them on full treatment until you approve the diagnosis or exclude the diagnosis. So this is this approach recommended by the British Thoracic Society, and I think it can be used as a baseline for our practice. And as I mentioned, it is not proven, so you have to assess the risk of bleeding, and also but having said that, you might be, in many cases, you might have to take that empirical decision, and you can use these guidelines as a baseline. So can we have the next slide, please? So we reach the end now of the lecture. We summarize the lecture now. So before the imaging, you have to assess the clinical probability. And the clinical probability recently has been simplified to 2 groups: pulmonary embolism likely and pulmonary embolism unlikely. And we mentioned that D-dimer is very useful test to try to avoid imaging, but led to more imaging rather than reducing the imaging. And therefore, we try to reduce the number of patients requiring D-dimer by using PERC, and which is pulmonary embolism rule-out criteria. But you have to understand the limitation of these criteria. And then age-adjusted D-dimer is also a very useful way of reducing imaging. And by age-adjusted D-dimer, people are above 50, you multiply the age by 10, and you can use that to exclude pulmonary embolism without doing imaging. Can we have the next slide, please? When we come to imaging, we can say that multi-detector CTPA is safe and to exclude pulmonary embolism as the sole imaging. And probably we don't need further testing. Having said that, people with high clinical probability and negative CTPA, whether we need testing, further testing or not, this is controversial, and each case should be dealt with individually, and you should use your own discretion. VQ scan still has got its uses, and it can be used in certain situations, especially if the patient has poor renal function or has got contrast allergy, and especially in young women with normal chest X-ray, where you wanted to avoid more radiation to the breast. And can we have the last slide? And then COVID-19, there is no doubt that there is increased prevalence of pulmonary embolism and DVT in patients with COVID-19, especially those with intensive care. And also, you have to remember, prophylactic anticoagulant does not prevent these people from developing pulmonary embolism. And because sometimes it is very difficult to validate or to do the CTPA in this patient, because the patient might be unstable, you might need some time to start this patient empirically on anticoagulant, and it's better to have some sort of risk stratification depending on the location of the patient, the severity of the disease, and the level of D-dimer. And the recommendation is to try to consider intermediate dose of low molecular weight heparin in high-risk patients. So people who are very ill, rather than give them 1 dose of enoxaparin and 1 dose of dalteparin, give them 2 doses of enoxaparin or 2 doses of dalteparin. And finally, consider therapeutic treatment in proven or suspected pulmonary embolism and keep a low threshold for suspecting pulmonary embolism. Can I have the next slide, which is the final, to say thank you for having me in this conference. I finish now.
Thank you very much, Dr. Muntasir Abdelaziz. That was an excellent talk.